Good evening, everybody, and welcome. Thank you for being here. And thank you guys for taking so much this time out to join us this evening as we spread awareness and celebrate National Infertility Awareness Week. My name is Lauren Esep, and I'm the chair of this wonderful and timely event. Did you know that 1 in 8 women have experienced infertility, whether it be female factor, male factor, or both? There are so many other infertility statistics, and therefore that's why we're here tonight. We will cover all things infertility tonight so that you can learn valuable information from our amazing and experienced guest speakers. At the end of our last speaker's presentation, we will have questions and answers. You can also feel free to put your questions in the chat window or jot your questions down to hold on to them until we get to that portion of the event. If you've submitted some questions on Eventbrite beforehand, like we had asked, we do have your questions and we will answer them as well. We may not get to all of your questions, but we will hold on to all of them and do our very best to get you all the answers because we know this event is very important and this information can be very useful to everybody on the call. So don't worry, we'll answer your questions. So now I would like to introduce our president, Cheryl Owens, and our vice president, Christy Holden of the Iota Gamma Omega chapter of Alpha Kappa Alpha Sorority Incorporated. So now we'll have Cheryl Owens bring us the greetings.
Good evening, everyone, and thank you for taking the time to join us this evening for this very important seminar or presentation on infertility. I've been through this with my daughter, and I always remember I took a picture of a sign in the NIC unit at Holy Cross Hospital that says, "Every birth is a miracle. Each child is heaven's gift." And I think that's very important and a great message because for those people who are struggling to have children, infertility can be very challenging. So I'm very appreciative for tonight for Dr. Hammond and Ms. Lipscomb-Warren for joining us and providing some expert information that I hope will be helpful to everyone as you move through this challenging time in your life, or just have some questions. So I appreciate the leadership of Lauren Estep and her committee in putting this together, and I hope you enjoy it. Thank you for joining us.
Thank you. So we'll go ahead and get our program started, and we will begin by listening to a short bio about Andrea Wiggins, and she will also follow up with her presentation on various assisted reproductive technology. This will be led by Ashley Thomas.
Good evening, everyone. So before we get started with the video, I'm going to give you a short bio of Ms. Andrea Wiggins. Dr. Andrea Wiggins is a general biological scientist and a strategic program manager for the Chemical and Biological Detection and Defense Program at the Department of Homeland Security, Science and Technology Directorate. She's a highly skilled interdisciplinary scientist with over 18 years of specialized training in genetics, molecular biology, neuroscience, toxicology, and biochemistry. Andrea obtained her Bachelor of Science in Biology with a minor in chemistry from the Bowie State University, and she holds a Master of Science and Doctorate in Genetics and Human Genetics from Howard University, the real HU. Her professional interests are topics associated with twin studies, endocrine genetics, neurological diseases, and disorders. Her doctoral research focused on neurodegeneration and potential mouse models to study Parkinson's disease. During her postdoctoral fellowship, she conducted inhalation studies for chemical warfare, CW, threat agents with comparisons of candidate medical countermeasures, and became a published author on acute cyanide toxicity. Dr. Wiggins assists in safeguarding the homeland from weapons of mass destruction, terrorism through projects to enhance and implement capabilities to prepare, prevent, mitigate, and respond to WMD threats. Understanding chemical and biology threats moving through an urban environment is critical in the protection of the nation. Dr. Wiggins recently received the 2022 Undersecretary's Pinnacle Award for Mission Excellence for the Science and Technology Directorate for her efforts within the CB defense sector. Outside of work, Andrea is a proud Air Force wife, mom to 4 children, newly minted Silver Star and Alpha Kappa Alpha Sorority Incorporated, avid DIYer, arts and crafts enthusiast, wedding and event planner, photographer, and interior painter. She also enjoys watching the Philadelphia Eagles games and sunsets from their home by the mountains with her husband and traveling with her family to new destinations. Without further ado, we will go ahead and look at the video on Dr. Andrea Wiggins.
Good evening, everyone. Thank you, Ashley, for that introduction. I am delighted to talk to everyone this evening about infertility and assisted reproductive technologies. I actually attended a lecture on endocrine genetics at Howard University as a graduate student in the medical school and was just floored by the advancement in the area of reproductive medicine. And so I'm just going to briefly talk about these items. Infertility is defined as not being able to get pregnant after 12 months or longer of having unprotected sex. In women, fertility declines steadily with age. And so in the medical community, we often call this advanced maternal age, which occurs around age 35. And it's commonly caused by problems that occur with ovulation, blocked or damaged fallopian tubes, as well as untreated STIs or sexually transmitted infections, and also disorders that occur within the ovaries, within the tubes, as well as the uterine and also the endocrine system. For men, fertility is commonly caused by problems in the ejaculation of semen, abnormal sperm function and also quality, and also hormonal disorders, and in some cases, advanced maternal age, which is designated by age 45. There are a number of tests that can be conducted to determine, woman's or man's fate or level of infertility by blood tests, ultrasound scans, x-rays, as well as laparoscopy. So for those who may have never heard the term assisted reproductive technology or ART, ART includes all fertility and treatments in which either the eggs or the embryos are handled. And so with ART procedures, it will involve surgically removing eggs from a woman's ovaries and then combining them with the sperm in a laboratory environment. And then they will be returned to either a woman's body or to a surrogate. What they do not include are treatments where only sperm are being handled. So in cases of artificial insemination, or during procedures in which a woman takes medicine only to stimulate egg production without the intention of actually having those eggs retrieved. So there are a number of different types of assisted reproductive technologies. The first being artificial insemination or assisted insemination. That's where you have sperm that's going to be washed and heavily concentrated and is then transferred by a catheter into the uterus or fallopian tubes around the time ovulation occurs. Around that time, it's very important because it will help increase the chances of fertilization. With in vitro fertilization, otherwise known as IVF, that is where you have an egg that's being removed from the woman and then fertilized with sperm in the lab setting. Those fertilized eggs are then going to be transferred into the uterus or the fallopian tube. Gamete intrafallopian transfer, also known as GIFT, is where you have unfertilized eggs or sperm that are transferred into one or both of the fallopian tubes using laparoscopy, which is otherwise known as a keyhole surgery, or something that's non-invasive, or it could also be transferred transvaginally with a transvaginal ultrasound. Intracytoplasmic sperm injection, or ICSI, is where the sperm is injected into the egg when there is no male infertility factor. So very similar to the image that you see currently on the screen. Zygote and intrafallopian transfer, are also known as ZIFT. It's very similar to GIFT, but it uses IVF. And so in this particular technology, Eggs are stimulated and then collected using IVF methods. The eggs are mixed with sperm in the lab, and then those fertilized eggs are then returned to the fallopian tubes using the keyhole surgery. Tubal embryo stage transfer, otherwise known as TEST, is very similar to both GIFT and ZIFT treatments, but these embryos are at a more advanced stage of development when they're being transferred into the woman than you would see in GIFT or ZIFT. Pronuclear stage tubal ligation, or PROST, that involves IVF of oocytes, and then it's followed by the transfer of pronuclear oocytes into the fallopian tubes. And then the last ART technology I wanted to cover today is laser-assisted hatching. And so this is where you have the zona pellucida, which is the outer shell of a fertilized egg that is gently thinned using an ultramodern laser. And using this particular technology, it actually greatly increases your chances of properly hatching, and it may also increase the chances of a successful implantation and also pregnancy. Thank you.
Thank you so much, Dr. Wiggins, for that wonderful presentation. We appreciate you and appreciate the work that you do. It was very good, valuable information, so thank you. Now we will have the short bio reading of Mrs. Ivori Lipscomb-Warren, and she will be followed by, after that, she will have her presentation. She is a phenomenal mom and infertility coach. Will be read by Ashley Thomas again. Thank you.
Thank you, Lauren. Ivori Lipscomb-Warren is an author, educator, speaker, and certified coach who specializes in infertility, pregnancy loss, postpartum, and mompreneurship. Her thought, leadership, and business acumen has placed her in rooms with global leaders in media, communications, hospitality, healthcare, and academic industries. Her entrepreneurship journey started as the founder of Ivori Nicole Events, where she led a highly acclaimed design team that crafted extraordinary events around the world for nearly 20 years. This is where her entrepreneurship muscle was strengthened, and she learned the ins and outs of a successful business. But it didn't stop there. After experiencing personal battles with infertility, pregnancy loss, and mature motherhood, she was inspired to help women just like her achieve a life they desire. Her passion for service to women led her to create a coaching practice dedicated to helping women purposefully design the life they love. Through holistic coaching, Ivori guides her clients to wholeheartedly follow their life and business pursuits and take the lead on themselves first and foremost. She operates under the principle that nothing is balanced until you are. With each client, she seeks to create a safe environment where people can live joyful lives fueled by gratifying work. Ivori holds a Bachelor of Science in Psychology, a Master of Art in Human Resources Management, and is a doctoral candidate currently completing her degree in Educational Leadership. In addition to managing her businesses and various speaking engagements, she is a training and development specialist and a professor of psychology and business management. Ivori continues her love of service on the board of directors for the Warren Foundation, a 501c3 nonprofit organization that specializes in support and awareness for several causes. These include pregnancy and infant loss awareness, youth mentorship, diabetes awareness, veteran transition, and educational support. She is also a member of the International Coach Federation, ICF, Forbes Coach Council, Resolve, the National Infertility Association, charter member of the Alpha Beta Gamma Omega chapter of Alpha Kappa Alpha Sorority Incorporated, and the National Coalition of 100 Black Women. Ivori's accolades are one for the books. She has gotten the opportunity to complete work across the world and has garnered features from Baltimore Business Journal as a 40 Under 40 awardee, Washingtonian, and CBS and Fox affiliates. Her resume aside, what brings her the most pride and joy is being a mother to her rainbow baby boy, Ian, and angels born into heaven. She is also married to her best friend of over 20 years, Kevin, and has 2 fur babies, Cole and Chloe. When she's not coaching women into pure happiness, she is watching A Different World, a Baltimore Ravens game, and indulging in pink bubblegum ice cream. To learn more about Ivori and her practice, please visit www.ivorynicole.com.
You could hear me better if I wasn't on mute. So good evening, everyone. Thank you for having me. And I just want to share briefly with you my journey from grieving and growing, from going to pain to passion, and why I do what I do within both the Warren Foundation and also with Ivori Nicole, as I purposely help women design a life they love. You can go to the next slide. So I'm going to share with you very briefly. This looks like a long thing. It has 7 items here, but it's really not, I promise you. And I know we're on a timeline, but I'm going to share with you my story. We're going to talk about hopes and dreams, going from pain to passion. What does that look like? Navigating infertility, how to support. So not just how you can support someone if you're going through it personally or getting support, but just all around, different resources and actually contact information as well. So my story, I have been telling my story and saying that it started in 2012. And I have to be completely honest that my story began in 2002 after 1 year of marriage and at the age of 25 and not 35 in 2012. At the age of 25, I was diagnosed with infertility. I didn't pay it any attention. I said, okay, I was recommended by my OBGYN to see a fertility specialist. And I said, okay, I'll do it later. Why? I had the life in front of me. I was just married for 1 year. I was going to, even though we had been together for 4 years by that time, but biological clock is real, but not really. Yes, but no. And so we were going to keep on with our lives. Moving forward, though, 10 years, fast forward to 2012, again, diagnosed with infertility at that time, 11 years married, right? So we've gone fast forward at 10 years, 11 years married, still no children, unprotected sex, no birth control. And it was hard. So what we decided to do at that time, because my OBGYN would see me annually and she would say, come back pregnant, Ivori, come back pregnant. We then decided to see a fertility specialist. We went, I had a biopsy, so I started the process and I stopped going after the biopsy because I was scared. I was scared because it hurt. I was scared because of the unknown. I am type A personality. I want to be in control of everything. And I said, no, not right now. Again, biological clock is real. But I had the world and my life in front of me. I wanted to travel. I wanted to chase my career. These are all the things that I wanted to do. Never said that I didn't want any kids, but in my mind, it was when God saw fit. Fast forward 5 years in 2017, I became pregnant naturally. Greatest time, never knew what you wanted until you lose it. And so next slide. This is me at the age of 5. This is me also at the age of 29. Hopes and dreams were in front of me. Again, never shared that with, I don't think I widely shared it, that I wanted children, but I did. I was not the little girl that grew up thinking about her princess wedding, as you may see here, but I was that little girl that grew up knowing that I wanted to be 2 things. One was a mom and the other was a teacher. That's all I knew. But again, my family pushed education, get the degrees, travel the world. That's exactly what I did. But as I mentioned, in 2017, my life changed. You can go to the next slide. That is actually when I went from pain to passion. In July of 2017, my husband and I found out that we were pregnant. We were excited, but more importantly, I think we were shocked. Remember, 5 years prior, again, diagnosed with infertility and unexplained. So there was no reasoning behind why we could not get pregnant. It was female factored, not male factored infertility. And so no explanation as to why. But we became pregnant naturally. We went away to a conference. We were in Florida. We went to Disney World. We were having a good time. I'm a big kid, love Mickey and Minnie Mouse. And so went to Florida as 2 and came back as 3. As a professor, the semester started. And at the same day, on August 21st of 2017, my miscarriage began as well. And I said began because my body naturally processed the loss for around 2.5 months. And so it's at that point that I went from pain to experiencing not just figuratively, but mentally, but physically going through pain. But I realized my passion. As you see here, this is when Loving Our Angel initiative started with our foundation. I'm a mommy to an angel. And this is when at that point, I realized that the biggest thing and the only thing that I had to do, or job that I felt that I had to do, was give my husband a child. I actually said to him as riding on the highway one day, and I looked at him straight face. I might have had a tear in my eye, probably not. I had already talked through it with myself as I looked at him and I said, Kevin, I want you to go have a baby with another woman. I'm glad he didn't, but he actually is at that point, he just looked at me. And again, I thought I had one job as a woman, and was to give my husband a baby. And he looked at me and he said, Ivori, we've been married for all of these years, over a decade at this point, well over a decade, approaching 2 decades of marriage. And that's not what he was there for. However, we then went back to our fertility specialist that I went to 5 years prior. But the delivery, the experience was completely different. I am at that time advanced maternal age. I'm at that time low ovarian reserve. What does that mean? As women, we are born, when we're born, we have all the eggs that we're going to have. But as we age, as we begin our menstrual cycle, we are losing those eggs. Whereas a man will continue to develop sperm. We do not continue to develop eggs. And so I experienced advanced maternal age, low ovarian reserve. The fertility specialist that I went to, who was excited and ready to treat me at the age of 35, it was completely different at the age of 40. We went through 1 cycle of IVF. It was not progressing well, so they stopped it and changed it to IUI, or intrauterine insemination. Unfortunately, that did not work. I'm no medical professional. However, I figured that if I did not get pregnant naturally, that wasn't going to work, and it didn't. And then we did a mini cycle of in vitro fertilization, or IVF. That was not successful either. We thought we were going to retrieve multiple eggs, and actually went through surgery to retrieve none. It was at that time, after that we sat in front of the doctor, and the doctor wrote out on a sheet of paper a figure. He turned the figure around to my husband and I, and it was a figure of $55,000 written on the paper. He said at that time that the only way that I would become pregnant is through a donor egg. I didn't know where $55,000 was going to come from. I did know, however, and I would say that my job actually covered infertility treatments 100%. So going through an infertility journey, it can be mentally draining, physically draining, and also financially draining. I didn't have that financial burden. And so I'll talk a little bit later about the resources that are available to assist in any financial treatments. And so I didn't have that. But what infertility treatment does not cover are donor eggs. And so it was at that time we discontinued service with that fertility center. And I did homework to have cargo travel, plane, train, automobile. I was ready to go anywhere. I started following doctors that were in Las Vegas, doctors that looked like me, anywhere, New York, I was willing to go because I wanted to be a mom. And so I wanted my husband to be a father. And the look on his face of when we were going through the loss, I will never forget it. And one thing that I want to say is that through this journey, we tend to focus on the women, but we also need to focus on our significant others as well, because while we're on this same journey, we're actually on two separate roads as well. And so I did my homework as a professional student, as I call myself. I did my homework and found a fertility center in my neck of the woods, right in my backyard. That happens to be an educational institution as well. And so I went and sought treatment there. I took my medical records with me. I had a consultation with them, and that was truly important. You can go to the next slide, please. And that's when you'll see this picture here, and I'll go into detail in a minute, but starting to navigate infertility. One of the biggest things that was important to me as I sought out a new fertility center is that I needed to be an advocate for myself, but I also needed my doctors, my medical team, to be an advocate for me as well. So who is not pictured here are my acupuncturist and my therapist. So it was truly important for me, and we don't talk about it in the Black community enough. I have a psychologist numbers in my phone, therapist numbers in my phone. If you need assistance, get it. And I knew that I could not travel this journey of grieving and growing and going from pain to passion without having that assistance. So I needed to make sure that I developed and created a medical team, a support team that could be optimistic for me when I was not able to, that was able to push me and support me. So not that was just not my husband, because 70% of relationships end after a loss, not because the couple does not love each other, but they don't know how to navigate it. And luckily that brought my husband and I closer together. But as I mentioned, I went and did an interview with my new reproductive endocrinologist. I brought all of my medical records stemming back to the age of 25, gave her everything coming full circle. And what I wanted to know was the bottom line. At the age of 40, approaching 41, did I need to do a donor egg, or could I become pregnant using my own eggs? And she was very optimistic. We were ready to get rocking and rolling, and we did just that. For 2 years, I went through 9 cycles of in vitro fertilization. The average cost, depending on where you're going, of in vitro fertilization is $20,000. Times 9, you can do the math. But again, I had insurance that covered my medicine, that covered my treatment through that. So if I paid anything out of pocket, it was no more than $500 if I needed to pay for medicine in that at all. But there was still the mental and the physical burden as well. I did 9 cycles over a 2-year span, because what we did at my age was called banking. We wanted to go through the treatments and make sure that we was able to retrieve the best quality eggs that we could. So after every egg retrieval, what we would do, the embryologist would watch my eggs if they matured for 5 days. So the embryologist, I called my eggs first babysitters, and they would inseminate them. And if they made it to a 5-day blastocyst, we would then send them for PGS testing or genetic testing. Why did we do that? It was because we wanted to make sure that the embryos were normal, find out if they were normal or abnormal. If they were abnormal, they were discarded. If they were normal, we were freezing them. And so we traveled that journey. And that was started in 2018. 2018. And we went and we did this song and dance. My body became tired. It stopped at some point going and working with the medicine. And so I knew that my body needed to stop, or I needed to stop, I would say, take a break. And so then we started our embryo transfers. The first embryo transfer did not take. And so I had to have a laparoscopic surgery called a hysteroscopy. And that was to find out what was going on. Found out that I just had a minor infection that all women have, nothing big, had some antibiotics. And it was truly important that I did that. My doctors knew that I was also, on this mission. I had my own timeline. I needed to get things done. But in life, things don't always happen when you want them to. And so this journey has taught me patience and to take a step back at times and listen to my body and listen to those of others. And so in listening and taking a step back, I needed to listen to my doctors. I had these doctors I trusted. They knew best. And so we wanted to make sure that I had that surgery, exploratory surgery, to find out what was going on before we transferred another embryo. We did a second embryo transfer. I became pregnant, but unfortunately I went through, can't talk this evening, another loss. And had to go through that and journey through that. And my doctor told me I would be pregnant by Christmas. And this was 2019. And I looked at her and I said, whatever, lady. I didn't believe her. I wasn't optimistic. I was gearing up for cycle 10. This is how I was getting my mind ready. And what I will say is that on December the 2nd of 2019, I had an embryo transfer. And on December 12th, 10 days later, the 2-week wait, the dreaded 2-week wait, I found out I was pregnant. So in this picture, to my left, you will see me in a pink suit and holding a hand of a woman. That woman is one, and she's actually my secondary reproductive endocrinologist. Annually, prior to COVID, the Warren Foundation hosted a luncheon called the Women of Strength Luncheon, where we were honoring mothers, moms of angel babies during the month of October for pregnancy and infant loss awareness. And we would have lunch, and then we would have a private conversation called Desserts and Conversation, where my medical team, my support team, my advocates would come. They would share their own personal stories. We became friends, and it family, actually, not even friends. And what is truly important, if you're on this journey, if you're supporting someone on this journey, if you're beginning this journey and you don't know which way to go, if your doctors, if your support system does not support you, please get second and third opinions. If your family and friends don't understand, it's okay. And you may need to pull back, and I did that. But if your doctor does not hold your hand through this journey, I'm gonna need you to find someone else, because it's important that you develop that relationship. It's not just that I'm going to have blood work done or ultrasounds done or things of that nature, but it's a very intimate process that you need that support and want them to be an advocate for you. The picture to the left are my two doctors. The one to the left of me, probably your right, or if you're looking at the screen, is your left as well. She was my primary reproductive endocrinologist. She was the medical director at the fertility center where I went. She was the woman that told me that I would become pregnant by Christmas, that I did not believe. She is the one that still calls me and checks on me. Even the other doctor in the first picture, she was down the hall giving birth to her twins while I was in the hospital during my pregnancy and sick. And she was checking on me. My primary doctor called me from Spain when she was on vacation to support me when she knew I didn't want to have that exploratory surgery. And the doctor to my right, it was my maternal fetal medicine doctor, my high risk doctor that supported me. Those are women that I love, that support me, that I can call on to this day, and I will always be grateful to them. Next slide. So support. What does that look like? I want to tell those that are friends or family that are watching this evening, that are going to watch the recording as well. If you don't know what to say, then say that. Instead of not knowing what to say and ghosting and disappearing, I want you to be honest. I want you to know that you're uncomfortable, that we're in an uncomfortable space. It's not to hurt your feelings, but you have to be uncomfortable in this uncomfortable space as well. So that is truly, truly important. Be there for your friends and family. If you don't know what to say, that is fine, but say that. If you need assistance, look up online. You can inbox me, Facebook, Instagram, ask. I have a loved one. I don't know what to say. I will help you through that. But this is a vulnerable time. And I will say that is the most important part. It's because at the time, and as you see in this picture, I did a photo shoot after my loss because I was trying to figure out how to journey through that. But the biggest thing, and I am very private, but I needed to share, God led me to share my journey so that I could be a voice for women. I did not see a lot of women that looked like us that were sharing their story. I was led to share my story, and my inbox started blowing up after I did that. And one thing that I want all women to know that are going through this and you've lost is that you're a mom. When women become pregnant, it doesn't matter the stage in the pregnancy, we are moms. And when we lose, unfortunately, we have lost the hopes and dreams, because when we find out we're pregnant, then we have planned this baby's life out. Don't know if it's boy or girl, multiples, we don't know, but we have planned their life out, and we're still moms. It doesn't matter the stage and that we lost, be it if it was a miscarriage, a chemical pregnancy, a stillbirth, we're still moms. And so I am 1 in 4 that have had multiple miscarriages. I am 1 in 8 of the couples that have experienced infertility. And I want you to know that you do have the support. Next slide. Some resources that are available. There's the Loving Our Angel initiative by my foundation, the Warren Foundation. There's Resolve. This week is National Infertility Awareness Week. They're a National Infertility Association that provides a lot of information as well. There's Fertility IQ for family building resources. And I'm excited to share, and she is speaking right after me, Dr. Camille Hammond of the CADE Foundation, and they help families overcoming infertility. Next slide. With that, I am Ivori Lipscomb-Warren. I'm an infertility and mom coach, and I help moms, I help women purposely design a life they love, ages 35 to 50, if they're going through infertility, if they've been diagnosed with infertility, deciding to go through treatments, deciding not to, going through pregnancy or processing infertility loss, motherhood at this age. I had a beautiful baby boy, August 3rd of 2020, the age of 43. And at 19 years of marriage, my son Ian will be 3 coming up on August 3rd. I'll be 46 and I'm chasing around a toddler, but I love it and I wouldn't change anything. I went through pain. The triggers are still there. They don't go away just because my son is here. But I have gone through passion to find my passion, and that's to help other women, to be a voice for women, and also the Chief Operating Officer of the Warren Foundation. And I thank you.
Thank you. Thank you. Thank you. Thank you so much, Mrs. Lipscomb-Warren, for that amazing presentation and overall inspiring testimony. I am positive that you have helped someone on this call tonight. So thank you. Everybody, also, please remember to put your questions in the chat if you have them, or remember to jot them down after the presenters are speaking so you don't forget when we get to the end. So lastly, we will now listen to a bio in the presentation of the amazing Dr. Camille Hammond, which will also be read by Ashley Thomas.
Thanks, Lauren. So Dr. Camille Hammond is a passionate nonprofit leader, reproductive health advocate, wife, and mother. She is a national expert in reproductive justice, adoption, education, infertility support, advocacy, and philanthropy. She is the co-founder and CEO of the Tinina CADE Foundation, and has authored papers and articles that have been published in peer-reviewed journals and magazines and newspapers throughout the U.S. Dr. Hammond completed medical school at the University of Maryland School of Medicine. She did her residency at the Johns Hopkins Medical Institution and her fellowship at the National Cancer Institute, as well as her master's in public health at the Johns Hopkins Bloomberg School of Public Health. She is the wife of her best friend, Jason, and mom to Aaron, Kai, and Simone. I present to you Dr. Camille Hammond.
Good evening, Source. Good evening. Thank you for welcoming me here. And it is my privilege to speak with you all about reproductive health and maternal health and issues around justice for women of color and women who may be at a disadvantage and who are more likely to have less desirable outcomes. So thank you for welcoming me this evening. Next slide, please. So I am 1 in 6. I know that they used to say that 1 in every 8 struggle with infertility, but that number has recently been updated by the World Health Organization to say actually 1 in every 6 people struggle to get pregnant within 1 year if they are under 35 and 6 months if they are 35 and older. So I am 1 in 6. And my story is very similar to the story that you heard this evening, the stories that you've heard this evening. I met my best friend in medical school, the first week of medical school, in fact. And after what I would consider a fairy tale courtship, we got married 3 years later and started trying to build our family the old-fashioned way. And after a year of trying unsuccessfully, I never actually got pregnant in that year, we started seeing the fertility doctors. And that started a 5-year journey through infertility treatment. And despite the fact that we were young and very healthy, that we had insurance, and we lived in a state where there was a mandate that required insurance to pay for our fertility treatment, or at least a portion of it, despite the fact that we had lots of knowledge, because we were actually in medical school when we started, we still struggled with the burden of infertility, and it almost broke us as a family. So 5 years into that journey, 6 unsuccessful rounds of IVF, and Ivori actually has shared about the cost of IVF. You can just do the math. We did have it covered, but you know that was still a huge cost to 6 rounds of IVF. The doctor said, you're out of money, you're out of insurance. And unfortunately, there's no reason to believe if you continue to spend this money that you don't have, that you're going to have a different outcome. So what are you going to do? What are you going to do different? And he suggested that we consider either adoption or something that he called a gestational carrier, which is commonly referred to as a surrogate. And that's when another woman carries your baby. Now, I didn't even know anyone who actually admitted that they had infertility, let alone have someone else carry a baby for them. So I was just devastated. My husband and I were ashamed. We felt like something was wrong with us. I knew something was wrong with me, and I did have endometriosis. But I felt broken as a woman. And some of the only people that we shared with about our story were my parents. And my mom and dad asked, well, what about your mother? You know, can she carry a baby for you? She carried 3 kids. She carried you, your sister, and your brother. And I was young and my husband was young, and, you know, we were doctors. We knew a lot, but we'd never heard about a woman carrying her grandchild, particularly a postmenopausal woman. I forgot to mention my mother had already gone through the change of life. So she was no longer having periods. So we politely thanked them, but declined. But my parents were persistent. And they said, you know, this is something we saw it on 60 Minutes. We think that this might be possible. And so after a lot of conversation and frankly, a lot of prayer, we decided to at least see if it were possible. And her doctor said, well, she's really healthy. We don't think it'll kill her, but we can't guarantee much beyond that, which was certainly not reassuring. But my parents had faith for all of us, and we moved forward. And about a year later, she delivered my triplets, who are now 18 years old. So the picture on the left is my mom and my dad about 3 years ago when the CADE Foundation had our annual gala. And by the way, my husband and I started a nonprofit that intended to support families with infertility in the same way that my parents helped support us with infertility. We named it after my mother. So Dr. Tinina CADE is my mother, and we founded the Tinina CADE Foundation to support families. The couple on the left is my mom and my dad. The group in the middle is my kids and my in-laws and my parents and my sister and her kids and just our extended family. And then on the right, that's a picture of my family, my kids, my 18-year-olds who are getting ready to graduate college. So, you know, this National Infertility Awareness Week, I really feel like I came full circle because I remember struggling. I remember wanting so badly to have children. And on the eve of NIAW, I was at Morehouse and Spelman College at the new student accepted weekend. So to have those two experiences was really just mind-blowing. So next slide, please. So you've heard about what infertility is and why it's important. Now we're going to talk about reproductive justice and why that is also an issue that you should care about. Next slide, please. Reproductive justice refers to the right to control our bodies, gender, and sexuality, and to choose when and if and how we will have children, and to care for those children in safe and healthy and sustainable environments. And that was actually coined by Black women in an organization that evolved into what is known today as Sister Song in the 90s. Next slide, please. Why is reproductive justice important? You may say the outcomes are the same for everyone, right? Wrong. Black women have the worst outcomes across the board for all of the outcomes, whether it is fertility, we're less likely to get pregnant. Whether it is, if you have fertility treatment, you're less likely to conceive using that treatment. If you do get pregnant, you're more likely to miscarry. If you stay pregnant, you're more likely to have a baby early, which places both the mom and the baby at risk for bad outcomes. You're also more likely to die in and around childbirth. So perinatal mortality for Black women rivals that for many third world developing countries that don't have the wealth and the resources that we have in this country. So when we talk about reproductive justice, we're talking about something so much bigger than what people understand. And I would look at it as almost the tip of the iceberg that you can see when there's so much beneath the surface. And unfortunately, I wish I could say that these are outcomes that are limited to fertility and family building. But if you look across many other disciplines in medicine, Black women, Black families, families of color have less desirable outcomes, and you need to know about it so that you can do something to increase the likelihood of your survival and of your family's thriving. Next slide, please. So let's talk about the Black fertility myth, because back in the 80s, there was this, actually it started before the 80s, but there's this myth that Black women are super fertile, right? Next slide, please. Wrong. Let's talk a little bit about the myths though. Black women don't have infertility. Of course not. We're super fertile. We have babies just by somebody looking at us. I'm sure many of us have heard that in our families with people talking. Next slide, please. Black women are super fertile. Next slide, please. The origins are in slavery, when Black women's value was based on their ability to bear children that could be monetized for slave owners. And so Black women having children was actually encouraged, esteemed, forced, required. And so Black women were looked at as being super fertile because they were forced to bear children, because that was a way for slave owners to make money off of them. Next slide, please. So again, the myth that Black and brown people are fertile, the data do not bear that out. It actually would suggest that the likelihood of Black women getting pregnant is lower than that of all other races across the board. And since 2007, fertility rates amongst Blacks and Hispanics have decreased significantly. And the problem is that we may perceive of ourselves as fertile, as more fertile than we are. And therefore, we may internalize when we don't get pregnant, and it may take longer for us to actually seek care. And the data would suggest that may result in Black women seeking care 1 to 2 years later. And 1 to 2 years can have that can mean something very different as far as your fertility. Ivori shared, you have all the eggs you're ever going to have when you're born. Women don't make new eggs. So if you're waiting, if you think that there's an issue when you are 32 and you wait until you're 34 to start receiving care or even to be diagnosed, the amount of egg reserve that you have, that those eggs can actually become babies, is much lower, which means your likelihood of conceiving is much lower. Next slide, please. It's not just a woman issue. It's an issue for Black men as well. But I do want to say infertility does not discriminate. It happens to everyone. Black women are just more likely, unfortunately, to experience infertility than white women. Next slide, please. Now, it's not just a kind of a historical issue or even an exposure issue. There is such a thing called provider bias, and that may mean your doctor perceives as Black women as being super fertile. So when you come in and you haven't had a baby, they may assume that you're not trying to get pregnant. They may assume that it's not something that's important to you, and so they may not refer you for diagnosis to see what's happening. They may not ask the question, is this something that you want, where they may ask it of another group of people. And studies have shown that provider bias is an issue, and it's an issue of concern. It's one of the social determinants that decrease the quality of healthcare. Next slide, please. So solutions, we've talked about problems. Let's talk about solutions. Next slide, please. So the secret is there's no secret. There's no magic bullet. There's no one thing that you can do that's going to fix all of this. This is a multi-layered problem, which is going to take a multi-layered solutions. And anybody who tells you, oh, just take this pill or run up and down the stairs 4 times or, pick something out of the sky, they're not giving you the full picture. And I'd be very careful about taking that advice. This is a lot, and it takes a multi-layered approach to address and move beyond. Next slide, please. So we're going to talk about 5 different areas that you can get involved with to increase your empowerment, your knowledge, and also hopefully make a difference in your life and your outcomes, as well as outcomes and opportunities for others. Patient education, provider education, laws, advocacy, and research. Next slide, please. How can we support patients with poor outcomes? First and foremost, events like the one that we are all sitting in right now provide a space for people to talk about the issues that they're having, to talk about the concerns that they've had that may or may not have been heard or responded to by their healthcare providers, and create models that invite people of color in particular to be their authentic selves and be heard and received. Number 2, educate and inform through personal stories, understanding the historical context, and also looking at local resources that may benefit families. And then thirdly, acknowledge the connection between reproductive health, mental health, and physical health. Now, Ivori spoke about the team of people who provided support to her on her journey. And I want to remind everyone that mental health is health. So there is no shame in getting mental health support. And infertility for some people is actually traumatic. When people have had recurrent miscarriage, that can be a traumatic issue. And the same types of support that are needed for other traumatic experiences can be necessary for families that are dealing with infertility. Next slide, please. Education and advocacy. Your voice matters, and it's okay for you to actually share your story with people in your community, as well as with people who make decisions that impact your health outcomes. And this is just an example of a program that the CADE Foundation participated in with a number of organizations that support Black and brown women: the Broken Brown Egg, Detox Now, White Dress Project, Eggs Over Easy, Fertility for Colored Girls, Warrior Wednesdays with Kelly Stewart, and then Semen Secrets. You may or may not have heard of some of these organizations, but these are all Black women-led national advocacy and support organizations. We hosted a reproductive justice summit at the American Society for Reproductive Medicine conference last year in Anaheim, California. It was a huge success. We're going to be doing another one at that conference this year. And this is an opportunity to listen to Black women, but also to have providers listen to Black voices because there may be blind spots. They may not know that they're not listening. They may not understand that they're not hearing people, what people are saying. Next slide, please. Eliminating reproductive and maternal health injustice. Now, I talked a little bit about poor maternal health outcomes, but it's a big deal. Black women, again, are dying unnecessarily of things that our maternal health deaths, our maternal deaths rival that of countries where they don't have the same access to money, resources, technology, etc. And it is senseless and it is unfortunate. So we need to work to decrease disparities in some of these social determinants of care that are negatively associated with poor access to healthcare or high quality healthcare and also poor outcomes. Now you say, what does that mean? Social determinants of care. Well, let's think about it. If you live in a neighborhood where there are no doctors or where there are very few doctors, it's going to be harder for you to get to the doctor for prenatal care, for diagnosis, for testing. Or also, if you have a job that's hourly and you don't have insurance, it's going to be harder, even if you live in a state where there is a mandate for insurance companies to cover a portion of the diagnosis and or treatment of infertility, but you work in an hourly job, right? So you don't have those benefits that are mandated simply because of where you work. Again, that is an example of a social determinant of healthcare. Religious objections. Unfortunately, in the Black community, there is a lot of myths, and many come from the faith side. When people don't understand, sometimes they just say, it's not God's will. God must not want you to be a parent. That's not true, because we don't say that when people are dealing with erectile dysfunction. We say, go get your blue pill and keep it moving, right? So, we've got to stop just kind of using religion to try and beat people up and make people feel bad. Okay, so I see a couple of people clapping, but their infertility has been referenced even back to the Bible, biblical days. And then we've talked about some of the fertility myths. Many of these really date back to slavery and, time when Black women's bodies were, well, they still to a degree are, but monetized, and their ability to have children was just a way that people could continue to make money off of them. Next slide, please. Black Maternal Health Week. The second week in April, and this is a slide from Black Mama Matter Alliance, Black Mamas Matter Alliance from 2022, but it was a big celebration and an opportunity to highlight the disparities in Black maternal health outcome, well, the difference between Black mothers and mothers of other races, and the fact that we're really at a critical stage. We're at a critical point where Black women are dying unnecessarily and something needs to change. And so this is just an example of, a week of activism, an announcement of a week of activism by this organizations, but organizations throughout the country were ringing the virtual alarm about this during Black Maternal Health Week, second week of April this year as well. Next slide, please. CADE Foundation, the nonprofit I run, was fortunate to be able to host the Maryland Reproductive and Maternal Health Justice Summit, along with several esteemed organizations that serve the Black and Brown community in Maryland. And we were able to ring the alarm and talk about the health disparities, the reproductive and maternal health disparities. We were able to talk about the community-based supports and solutions available. And then we were able to talk about the legislation, because the legislation is an important tool that can very easily grant thousands, tens of thousands, hundreds of thousands of people access to high quality healthcare by simply mandating or changing the law to say this is required, or allocating dollars to fund research and also to fund interventions that are shown to improve outcomes. And we were really fortunate to have several legislators present. We talked about the Momnibus legislation that was created by Congresswoman Lauren Underwood that allocated dollars to improving maternal health outcomes for Black women. And then also we had Stephanie Madden Smith, the Congresswoman from Maryland, the representative from Maryland, who has authored several bills intended to improve access to reproductive care in the state of Maryland. So we were able to meet with the legislators, let them know what's important to us, but also learn about the laws that are in existence and those that were proposed, so that we are ready when we go to the ballot box to vote to support laws that will increase access to healthcare. And then also on the other side, to defeat laws, to defeat proposals that are going to harm our access to high quality healthcare. Next slide, please. This is just, again, the slide. We did the Reproductive Justice Summit at the American Society for Reproductive Medicine meeting last year. And you'll see it's women and men. It's not just a woman thing. Infertility is not a woman thing. 1/3 of cases of infertility are female factor, 1/3 are male factor, and 1/3 are both or unknown. And we're going to be doing it again this year in Louisiana at their conference. And we're also going to be having a Georgia maternal reproductive and maternal health justice summit in Georgia on September the 6th. Next slide, please. Another tool that can be used to help address this is money. So sometimes people know what the issues are. They know where the resources are, but they can't afford to pay for the resources. And so, we can either come up with ways to give people more money to pay for existing services, or come up with ways to decrease the cost of services. And I think that there are innovative companies that are working on both sides of that. CADE Foundation is one of a handful of organizations that offer grants. Our grants provide up to $10,000 for fertility treatment, or adoption. But also, there are a number of clinics that have come up with ways to decrease the cost of IVF cycles. And I have highlighted one. CNY charges about $4,500 for a cycle, as opposed to the, $12,000 to $15,000 that is charged generally across the board. The way that they decrease the cost is, instead of having a physician who's gone to medical school and has, X number of years in training, who is providing the care, they have a nurse practitioner that's doing the monitoring. And the nurse practitioner has been trained, but they're not a physician. But that is one way that they have decreased the cost. And as well as something called mini IVF or natural cycle IVF. I think that, again, a multi-layered approach is going to be essential for people for addressing this issue. Next slide, please. Provider education to limit implicit bias. I would scream this if I didn't want to hurt your ears right now, But first of all, we got to accept that bias is an issue. We all have biases. I prefer chocolate. Some people hate chocolate. So if you give me if you give me an option, I'm going to go for the chocolate cake. Now, that's an issue that nobody really cares about. But when a patient walks into the room, what do you assume about them based on what they look like? Do you assume that they're intelligent? Do you assume that they care about family building? Do you assume that they work? Do you assume that they deserve to be parents? These are things that take a split second to decide. And sometimes we may be embarrassed for other people to know what we assume, but bias is real. So in order to address the impact of bias, physicians and healthcare providers, because I'm saying physicians, but nurses, nurse practitioners, there are a lot of people involved in providing healthcare. We've got to acknowledge that bias is an issue, and we've got to work really hard to limit the impact of our personal biases on the healthcare that is provided to people. I think that mandated implicit bias training is an important step. I know in Maryland last year, I was required to check a box, for instance, to say that I had received implicit bias training. Nobody checked to see if I was telling the truth. There was no additional follow-up information asked. Where did I get it? When did I get it? So it would be very easy for people to lie to say I got it so I can renew my license and not have actually done it and not benefited from that training. But I think mandating that it be done is an important first step. And there are several specialties in medicine that have required this training in order to be certified and credentialed. Next slide, please. Also, looking at the impact of reproductive and maternal injustice on the individual. I think we've got to acknowledge, we talked about the impact of slavery, but we didn't talk about the impact of Tuskegee or Henrietta Lacks or Black women who were whose fertility was stolen from them by racist doctors who just decided they didn't need any more babies. And so they were sterilized without their consent. The father of OBGYN, of obstetrics and gynecology, is the man who was able to describe and draw pictures of women's anatomy in very good detail. The reason why he was able to do that is because he purchased 3 women who were enslaved, and he operated on them. He cut them open while they were awake without anesthesia. So he studied their internal organs while they were awake. We call that torture. Okay. So the knowledge that was gleaned has helped women, for generations, but those women were tortured. 20, 30 surgeries per woman. Okay. And this man is looked at as a hero. He's called the father of obstetrics and gynecology. I'm going to quickly talk about Tuskegee. I think that there's a little bit of confusion. Some people say, oh, those men were given syphilis. They were not given syphilis. They were just not given the treatment, which is still unconscionable. And at this point, there are all types of informed consents that are required for any kind of study, so that you have to provide a treatment if one is available. But I just wanted you to understand that the Tuskegee study was unconscionable because they were not given the treatment that would have cured their syphilis, but they were not actually given syphilis. Henrietta Lacks is an important woman. She's from Baltimore. So I live in Baltimore. She's from this area. She was poor. She was Black. She was a tobacco farmer, actually. And she went to the hospital and died a few days later. She had cervical cancer. And the thing about her cervical cancer that made it unique is the cells never died. Every day, they replaced themselves 100%. So if on day 1 there was 1 cell, On day 2, there was 2 cells. On day 3, there was 4 cells. On day 4, there were 8 cells, so on and so forth. So they were considered immortal because they continued to replicate themselves. So her cells were taken without her consent, and they're still alive now. I mean, she's been dead for a long time. Billions of dollars have been made using her cells because, again, they will replace themselves every 24 hours. And cures have been created using the knowledge that from studying her cells and using her cells to test medications and test treatments and such. And despite the fact that billions have been generated, her family did not financially benefit at all. She didn't have a headstone until recently. And so, that's another reason why for so many people, there's a real mistrust of the medical system. Next slide, please. So we've talked about addressing implicit bias in healthcare. Another way that we do that is through grand rounds and academic publications. I know that the CADE Foundation works really hard to work with medical schools and academic training institutions, because those are new doctors, those are young doctors. It's a lot easier to impact the type of care in the kind of the practice pattern of people who are developing their practice pattern than to impact and change people who've been in a field for 50 years. They've been doing the same thing. So we really have focused on those who are younger in the field. And so we've worked with Johns Hopkins for the past, 6-7 years, the University of Maryland School of Medicine. And this year we started working with Georgetown, creating these grand rounds presentations where doctors, they have to do grand rounds, they're educated through grand rounds talks. And we talk about issues of importance in the reproductive health space. And then I also spoke briefly earlier about the implicit bias training, and it is required, it's mandated in Maryland, California, Michigan, and Washington states. In order to get recertified or to get your license, you have to have taken this implicit bias training. Next slide, please. And then the laws. That's where it starts. That's where it ends. That is the easiest way to improve access to high quality healthcare. Let's get some more laws on the books. Let's get informed about the laws that have been proposed, because there have been a lot of laws that have been proposed that have been, I feel, kind of discussed in the middle of the night without much opportunity for the public to provide feedback. And then you wake up and then, 100,000 women just had their rights taken away because of some shady middle of the night conversations from people who really had a non-health agenda. They had more of a political agenda than a health agenda. So we need to know what's being done, what's being proposed, so that we can act in our best interest and in the best interest of our community. Next slide, please. And, this is a little bit more about that. 20 states have passed the laws requiring insurance cuts. So the mandate, when I talk about mandates, I mean legislation requiring insurance companies to cover at least a portion of the diagnosis and or treatment. Now, recently, with just a decision, the largest employer in the United States, the Office of Personnel Management, i.e. the government, added fertility coverage. It's an option for all government employees in 2023. Now, it's not everything. It's diagnosis and the medications. So the actual treatment is not required for all people, but that's more than has ever been an option for government employees. And that's just happened in 2023. And there are laws pending in many states that would mandate fertility diagnosis and treatment for some, and also for fertility preservation. And then there are some states that are working at a rapid pace, honestly, to eliminate fertility treatment, to make that illegal. and remove that as an option for women. So it's important to know what's going on, what's going on in your state capital. That's not just somebody else's issue. That's important. That's your issue. That's important for you, your family, your future, and your community. Next slide, please. And this is just, I know that I'm over time. So, this is part of the Momnibus legislation. Momnibus, again, I talked about it, Congresswoman Lauren Underwood. It was 12 bills that she pulled together that all increased revenue for specific activities that would improve, decrease Black maternal health deaths and improve Black maternal health outcomes. This is just one of those bills that were pulled together and collectively called Momnibus. Next slide, please. And you can, please, next slide. This is more about that. So I'm going to end with, now is the time. Here is the place. We need to get loud. We need to understand what's going on with our bodies. We need to understand the historical context. We need to identify local community supports, but we need to be active and engaged with what is happening on the legislative side so that we can amplify and support those bills that are going to help us and improve our access to care and our access to high quality healthcare. And we need to defeat those that are going to harm us and to harm people that are already more likely to have bad outcomes. Now is the time. Thank you. Real briefly, this is National Infertility Awareness Week. I hope that this is, if this is the first NIAW event that you have attended, thank you for being a part of this. But I will say that there are things going on throughout the country, online and in person. These are just a couple of examples of things that are going on at this time. Advocacy Day for Resolve and the American Society of Reproductive Medicine was on Tuesday. There was a Polycystic Ovary Syndrome Advocacy Day in March, and this is the Reproductive Justice event. This is an example of advocacy in action. These are a couple of events that the slide to the left is me standing next to Congresswoman Lauren Underwood. And there was a letter writing campaign where letters were sent to the leaders in Congress to express support, or frankly, if people didn't want them to support the Momnibus legislation. So these are just examples of the letters. We sent hundreds of letters to congressional leaders. And then on the slide on the right is one of our reproductive and maternal health justice summit events. And it was hybrid. So we had a couple hundred people online. And then we also had watch parties throughout the state so that people could engage and connect with local resources if they wanted to. But this is all a part of advocacy, using your voice. Your voice matters, and it's necessary. Next slide, please. Thank you. I appreciate your time, and I'd be happy to answer any questions. Lastly, the CADE Foundation is hosting a Race for the Family, and it's going to be in Gaithersburg on June the 11th, and we're actually going to be giving away $10,000 in treatment at Shady Grove Fertility, which is one of the largest fertility groups in the world. You don't have to be present to win. We do have virtual attendance possible. And if you'd like more information about the race, where we will have lots and lots of support on site, and we'll even have support. We will have even a place for the little rainbow babies. We call it Savannah's Playground. Please come out and walk and fun run with us, and let's grow together. Thank you.
Thank you so much, Dr. Hammond, for that presentation. And I agree, and I hope everybody is ready to start getting loud. It is time to get loud. We need to be knowledgeable about our own healthcare, what's going on with us. so that we can really advocate for ourselves, because at the end of the day, we're the only ones that can do it the best. So I appreciate that. And it's amazing what you're doing for people like us. You're not alone in this situation. Like we talked about some of the statistics in the beginning, is 1 in 6, 1 in 4, 1 in 8. There's so many different ones. I'm actually 1 in 8. So I just wanted to, if you're comfortable, if there is anyone on the call that fits any of those statistics, do you mind coming off mute and just being a part of the community and saying what your number is? I'm 1 in 6, 1 in 8, 1 in 4. So you can go now if you choose to.
1 in 6, 1 in 8, and 1 in 4.
Anybody else want to share?
One in 4, 1 in 8.
Okay. Okay. And I am 1 in 8. And if we were in front of each other, we all could have a big powwow and hug. So that's just proof. If you look in any of your circles, your coworkers, your friends, there's someone around you that have been through the same thing. So don't suffer in silence.